1, 2,
And
Patients here.
female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
Usually, when we talk about a medical diagnosis, there's this expectation of like precision.
Right, yeah, a clear-cut answer.
Exactly. You know, you break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is.
It's broken or it's not. It's entirely binary.
Yeah, binary. Because the human mind just craves that kind of visual, categorical certainty. We want a clear villain to target.
We really do.
But then you step into the world of neurodevelopment or trauma and cognitive decline, and suddenly that x-ray machine is just useless.
Completely useless. You are staring into diagnostic muddy waters at that point.
Muddy waters is the perfect way to put it. And, you know, if you, the dedicated nursing student or the clinician standing at that bedside, if your mission isn't just passing a pharmacology exam, but actually catching a life-threatening medical emergency before it's too late,
yeah,
well, you need more than just textbook definitions.
You need to understand the underlying mechanisms. Absolutely.
Right? So today we are doing a deep dive into authoritative clinical guidelines on cognitive disorders. We're acting as your elite psychiatric nursing educators, pulling out the exact pathophysiology, pharmacology, and care plans for delirium and dementia.
And we are focusing specifically on the knowledge that directly impacts patient outcomes, the stuff you must know for exams like the NCLEX and for real-world safety.
Because these disorders are notoriously tricky, right?
Right, oh, incredibly tricky, because the behavioral symptoms overlap so heavily in clinical practice.
Like you could have two patients both exhibiting profound confusion, both highly agitated.
But the underlying physiological mechanisms are completely different, and therefore the required nursing interventions are often the exact opposite of each other.
The exact opposite. Which means if a nurse just relies on like basic intuition without understanding the neurobiology, they actually risk actively harming the patient.
They absolutely do.
So before we get into the granular stuff, let's establish our ultimate baseline. Applying the 80-20 rule to this clinical text.
The 20% of foundational knowledge that gives you 80% of the clinical understanding.
Right. So what are the defining differences between the big two, delirium and dementia?
Well, the absolute core differentiator really comes down to the timeline and the integrity of the patient's level of consciousness.
Okay, so let's start with delirium.
So delirium is an acute, rapid onset condition. We are talking about a shift that happened over hours or maybe a few days at most.
It's fast.
Very fast. And the patient's level of consciousness will actively fluctuate throughout the day. But most importantly, and this is a huge testable concept, delirium is almost always a reversible medical emergency.
Reversible?
Yeah.
Because it's caused by something else.
Exactly. It is secondary to a distinct physiological insult, like a systemic infection, severe hypoxia, or an acute drug toxicity.
Okay, so I was thinking about this dynamic earlier, and I want to test an analogy with you.
Sure, let's hear it.
If we view the human brain as a computer system, delirium seems to function like a sudden software crash caused by a massive power surge.
Oh, I like that.
Right.
Yeah.
Like the physical hardware is technically fine,
Yeah.
but the system is just completely glitching out right now because the electrical input is corrupted.
Yes.
But then dementia, on the other hand, seems like the actual hard drive is physically degrading. Like the sectors are permanently corrupting over a period of years.
That analogy perfectly dictates the required clinical response, honestly. Because if a patient is experiencing that acute power surge, the delirium, the nurse's immediate job is to reboot the system and fix the power source.
You have to find the surge.
Exactly.
Yeah.
You hunt down that urinary tract infection, you correct the electrolyte imbalance, you restore the oxygenation.
But if they have dementia...
If it's the slowly degrading hard drive, your clinical mandate changes entirely. You cannot fix the hard drive.
Right. It's irreversible.
So your job is to manage the failing hardware safely. You preserve whatever data and dignity are left for as long as possible, and you adapt the operating environment so the system can still function without just a total catastrophic failure.
And understanding whether you're dealing with a power surge or a degrading hard drive, I mean, that dictates your primary safety risks.
It does, which is why the text heavily emphasizes that a sudden onset of confusion in an older adult is never, and I mean never, just old age.
Never. That's such a critical red flag for our listeners.
It's perhaps the most dangerous myth in geriatric healthcare. Sudden confusion requires an immediate, aggressive medical workup. You have to assume it is delirium until proven otherwise by a physician.
Because if you just dismiss it like, oh, they're just getting senile.
You will miss a fatal sepsis infection or an impending stroke.
Wow. And the injury risks really mirror that underlying physiology too, don't they?
They do. If the brain is progressively degrading over years with dementia, the safety risks are things like wandering out of the house or, experiencing severe emotional trauma because they suddenly can't recognize their own living room.
But if the brain is acutely glitching from that power surge,
the immediate threat is the patient actively ripping out their life-saving intravenous lines or pulling out urinary catheters, or impulsively vaulting over the bed rails because they're actively hallucinating.
yeah, it's a totally different level of immediate physical danger.
Yeah.
And the pharmacological interventions follow that same strict division, right?
Absolutely. With dementia, your primary long-term tools are choline esterase inhibitors. Those attempt to slow the inevitable progression.
Right, but they don't cure it.
No, they don't. And the text highlights a massive critical red flag regarding medication safety here. The black box warning for antipsychotics.
Oh, this is huge. The guidelines are incredibly strict about not using antipsychotics to manage behavioral disturbances in older adults with dementia-related psychosis,
Because doing so significantly increases their risk of all-cause mortality.
like cardiovascular complications.
Yes, sudden cardiovascular events and severe infections like aspiration pneumonia. It's a profound risk. You have to exhaust non-pharmacological interventions first.
Which naturally leads us to the communication strategies.
Yeah.
Because this is where the interventions represent like a massive shift in how we intuitively want to interact with confused people.
Right, because if a patient is delirious, the power surge, we use reality orientation.
Because their brain still retains the structural capacity to process reality. It's just temporarily misfiring.
Exactly. But if we try to force reality onto a patient with advanced dementia, we actually trigger catastrophic emotional trauma.
And that's where our clinical intuition actually betrays us, isn't it?
It really does. Your instinct is to correct the patient. You want to tell them the truth about where they are or, what year it is.
To help them.
Right, to help. But forcing reality onto a brain that literally lacks the physical neuroanatomy to retain new information, it doesn't orient them, it just corners them.
It corners them. Wow.
That is why validation therapy is the gold standard for dementia, while reality orientation is critical for delirium.
Okay, that is a perfect transition. Let's follow that logic straight into the pathophysiology of delirium. We know it's a transient syndrome, a disturbance of consciousness with a severe change in cognition. But who is actually getting this? Like, who is experiencing this acute physiological disruption?
Well, the primary demographic is older adults, and the statistics are alarming. Roughly 1/3 of all hospitalized patients over the age of 70 experience delirium.
1/3.
Yes. And half of them present to the emergency department already delirious. The other half develop it as a direct result of their hospitalization.
Which implies that the hospital environment itself is an active catalyst.
It absolutely is. I mean, the incidence skyrockets in intensive care units.
Oh, ICU psychosis.
Exactly. What we historically called ICU psychosis is almost entirely delirium, driven by sensory overload, sleep deprivation, continuous artificial lighting, heavy sedation.
That makes total sense.
We also see a massive prevalence in post-surgical units as patients are metabolizing anesthesia. And in palliative care, up to 80% of palliative patients become delirious in the active dying process as multi-organ failure sets in.
Wait, are children at risk too?
Yes, it's important to note that very young children are highly susceptible, usually related to febrile illnesses where a rapidly spiking temperature acutely disrupts their cerebral metabolism.
So really, anything that severely stresses the body's physiological homeostasis can trigger this.
Exactly.
The text provides exhaustive lists of etiologies, but polypharmacy and systemic infections seem to be the absolute most common culprits.
Without a doubt.
Let's isolate that infection mechanism, because the scenario of an older adult getting a urinary tract infection and then suddenly hallucinating, that is ubiquitous in clinical practice.
Oh, you will see it constantly.
So why does a localized bladder infection cause a brain to generate false visual data? Like, how does that jump happen?
It is a fascinating cascade of systemic inflammation. When an older adult develops a UTI, their immune system mounts a defense, right? It releases a flood of inflammatory cytokines.
Proteins like interleukin-6 and tumor necrosis factor.
Exactly. Now, in a younger, robust individual, the blood-brain barrier acts as a fortress. It keeps those systemic inflammatory markers out of the central nervous system.
But in an older adult,
Yeah.
that barrier is compromised.
Precisely. The aging blood-brain barrier is naturally more permeable, so those circulating inflammatory cytokines actually slip through the barrier and enter the brain tissue.
Wow.
And once inside, they activate the brain's own immune cells, the microglia. The microglia panic, essentially, and release a massive wave of oxidative stress and neurotoxin.
Which then disrupts the neurotransmitters.
Right. It severely disrupts the synthesis and release of crucial neurotransmitters, particularly acetylcholine and dopamine.
So the localized bladder infection essentially orchestrates a massive chemical imbalance in the brain. The acetylcholine drops, the dopamine spikes, and suddenly the brain's ability to filter sensory input and maintain consciousness just completely fractures.
That neurochemical chaos is exactly what produces the subjective and objective findings of delirium. And the hallmark of this state is extreme fluctuation.
Right. The symptoms change wildly throughout the day.
The patient is not statically confused. I mean, they might be sitting quietly, perfectly lucid at 10:00 a.m., having a completely rational conversation with their family. And then by 2:00 p.m., they are screaming in terror because they genuinely believe the room is filling with water.
That sensory processing failure leads to a really critical distinction in the source material. It's very careful to separate illusions from hallucinations for the purpose of nursing assessment.
Yes, and they require entirely different diagnostic interpretations. An illusion is a misinterpretation of a real environmental stimulus.
So, like, the object is real, but the translation is corrupted.
Exactly. The patient's optic nerve takes in the visual data of, say, an intravenous fluid line coiled on the floor, but the inflamed, glitching brain interprets that visual data as a snake.
Right, whereas a hallucination is the brain entirely fabricating data without any external stimulus at all.
Correct. The patient perceives angels hovering over the bed or insects crawling on the blank walls when there is absolutely nothing there to misinterpret.
And crucially, in delirium, if hallucinations are present, they are overwhelmingly visual, right?
Yes, usually visual. Auditory hallucinations are far more indicative of a primary psychiatric disorder, like schizophrenia.
Okay, so how does all this internal chaos actually manifest physically? Do these patients all present with that hyperactive, aggressive agitation?
Actually, no. The presentation is highly variable. The hyperactive delirium is definitely the most recognizable.
Right, because they're restless, pacing, aggressively picking at their bedclothes.
Right. Trying to climb over the bed rails, speaking rapidly and loudly. They demand attention because they are so disruptive to the unit. But the hypoactive delirium is far more insidious.
Because they just look like they are sleeping?
Yes. They appear sluggish, severely lethargic, slow to respond. They might just stare blankly at the wall. And clinicians frequently miss hypoactive delirium because the patient isn't causing a problem on the unit.
Wow, they're just quiet.
They're just quietly slipping into profound metabolic failure.
Yep.
And the mortality rate for unrecognized hypoactive delirium is exceptionally high because the underlying cause, the hypoxia or the sepsis, it just goes entirely untreated.
That makes the priority nursing assessment an absolute life or death scenario. You can't just document patient appears confused and move on with your day.
Never.
So what is the precise diagnostic protocol when a nurse encounters this? Let's give our listeners the exact steps.
The nurse must immediately adopt an investigative mindset. That absolute first step is assessing for the underlying physiological cause. You pull a comprehensive set of vital signs to rule out fever or hemodynamic instability.
Right.
You check their oxygen saturation to rule out acute hypoxia. You draw blood for a comprehensive metabolic panel to check for severe hyponatremia or hypercalcemia. You obtain a urinalysis.
And the medication review, we have to look at the polypharmacy aspect.
The medication reconciliation must be ruthless. You are looking for newly prescribed drugs, potentially lethal drug-to-drug interactions, or impaired renal function that has allowed a normal dose of a medication to just build up to toxic levels in the bloodstream.
What kinds of drugs are the biggest offenders here?
Anticholinergic drugs, certain pain medications, and even over-the-counter sleep aids. They are notorious for tipping a vulnerable patient into delirium.
Okay, so while you are pulling all these labs and reviewing the charts, the patient is still actively hallucinating in the bed. How do we manage the immediate physical safety of someone whose reality is fracturing? Because the instinct, particularly if they're trying to, pull out a necessary breathing tube, might be to just use physical restraints.
The guidelines are unequivocal on this. Physical restraints are an absolute last resort.
A last resort.
They are to be used only when every other de-escalation tactic has failed, and the patient's immediate survival depends on a medical device staying in place.
Let's break down the physiological reason for avoiding restraints. Beyond just the obvious ethical considerations, why does tying down a delirious patient actively worsen their medical condition?
It's a great question. When a patient is delirious, they completely lack the cognitive capacity to understand that the restraints are for their safety.
Right, they can't process that.
To them, they are suddenly bound and under attack. This triggers a massive sympathetic nervous system response. It's a literal fight-or-flight adrenaline dump. They will fight against those leather or soft restraints with everything they have.
They will fight until muscle breakdown occurs.
Exactly. They exhaust themselves to the point of rhabdomyolysis, which is severe muscle tissue breakdown. They develop severe lactic acidosis from the extreme exertion.
Which just demands more oxygen.
Yes. This astronomical spike in metabolic demand further starves the already compromised brain of oxygen and glucose, which deepens the neurochemical chaos. You aren't just making them angry, you are actively accelerating the failure of their central nervous system.
So, if restraints are off the table, the interventions must focus on milieu management.
Manipulating the physical environment, yes.
How do we do that effectively?
You utilize one-to-one sitters to provide constant, gentle redirection. You provide the patient with safe, tactile distractions.
Like what?
Like a towel to fold or a specialized activity apron, anything to keep their hands busy and away from their IV lines.
And what about the sensory environment? Because earlier we talked about sensory overload.
The goal is to minimize sensory overload while maximizing reality grounding cues. So you keep the room well lit.
Wait, that seems really counterintuitive. If their brain is overloaded, shouldn't we darken the room to let them rest?
A dark room is a breeding ground for visual illusions.
Oh.
If the lighting is dim, a shadow cast by an IV pole easily looks like a looming figure. A folded blanket at the foot of the bed looks like an animal. Bright, clear lighting eliminates shadows and helps the brain accurately process the geometry of the room.
That is brilliant. Okay, so keep the lights on.
Keep them on. You also minimize auditory noise, turn off the television, silence the IV pump alarms immediately when they beep, and limit visitors to one calm family member at a time. A room full of people talking simultaneously will overwhelm their auditory processing instantly.
Okay, but if the environmental modifications fail, and the patient is still posing an imminent danger to themselves, what pharmacological tools do we actually have to stabilize that misfiring brain?
I must reiterate that the absolute first-line treatment is curing the underlying disease. You administer the antibiotics for the UTI. You provide the supplemental oxygen.
Right, fix the power source.
Exactly. But for severe, dangerous agitation or terrifying psychosis that actively prevents life-saving care, the provider may order a very low dose of a conventional antipsychotic.
Like haloperidol.
Most commonly haloperidol, yes. We are talking about 0.5 milligram to 1 milligram administered orally or intramuscularly.
But there is a massive contraindication regarding a different class of sedatives here that students always get tested on.
Yes, you absolutely must avoid benzodiazepines. Medications like lorazepam or alprazolam.
Why?
Because in the aging, delirious brain, benzodiazepines frequently trigger a paradoxical reaction. Instead of calming the patient down, the drug disinhibits them further. It significantly worsens the agitation, the confusion, and the risk of injury.
There is one highly specific exception to that rule, though, correct?
Yes. The only time benzodiazepines are the gold standard for a delirium is when the delirium is specifically induced by acute alcohol withdrawal, what we call delirium tremens.
Okay, let's unpack that. Why does that exception exist?
Because alcohol acts as a massive central nervous system depressant by binding to GABA receptors. When a chronic alcoholic stops drinking, the brain goes into severe hyperexcitability. Benzodiazepines bind to those exact same GABA receptors, effectively replacing the alcohol, stabilizing the electrical activity, and preventing fatal withdrawal seizures.
Got it.
But for delirium caused by sepsis or hypoxia, benzodiazepines are strictly contraindicated.
That distinction right there highlights why the initial diagnostic detective work is so vital. Now let's look at how we communicate during this crisis. If the patient is terrified of a hallucination, how do we verbally intervene?
You maintain a calm, low-pitched voice. You use simple, declarative sentences, and you allow the patient ample time to process your words. The core strategy here is reality orientation. You correct their misperceptions matter-of-factly.
The source text provides a brilliant clinical scenario for this.
Oh, the laundry cart.
Yes. So a delirious patient hears a loud crash out in the hallway, becomes deeply terrified, and asks the nurse if a bomb just exploded. What is the therapeutic response that grounds them without, dismissing their fear?
The ideal response acknowledges the emotional reality while firmly presenting the objective reality. So you say, no, there was no explosion. That was a heavy laundry cart banging into the wall in the hallway. It was incredibly loud, wasn't it? It startled me, too.
It startled me, too. That is profound empathy.
It is deeply validating. You do not play into the delusion, but you don't minimize their autonomic nervous system's response to the stimulus. You validate the fear, but you provide the logical frame to interpret it.
I want to pressure test everything we just discussed with a building clinical judgment scenario pulled directly from the text. This paints such a vivid picture of how ambiguous these presentations can be in the field.
Let's do it.
Okay, here's the background. An ambulance arrives at the emergency department with an older woman. Neighbors called 911 after seeing her walking aimlessly down the middle of the street, completely dazed, not responding to her name. And the neighbors reported to the paramedics that they assumed she was suffering from severe dementia.
The classic trap, assuming cognitive decline based purely on age and confusion.
Exactly. But here is the objective assessment data when she actually arrives in the trauma bay. The woman is dressed in heavy clothing suitable for gardening, including thick gloves, and she has pruning shears in her pocket. It is a hot, humid afternoon in late August. She is completely unable to answer questions or identify herself. Her core body temperature is 103.2 degrees Fahrenheit, and she is perspiring profusely, though her skin is flushed.
This is a phenomenal case study for clinical triage.
Right, because the neighbors assumed dementia, the degrading hard drive.
But based on our 80-20 rule, this sudden severe confusion resulting in a total loss of orientation screams delirium.
And the power source crashing her system is glaringly obvious. It's August, she's in heavy gardening clothes, her temperature is 103.2. This is severe heat stroke and profound dehydration causing an acute neurochemical crash.
The top priority is immediate physiological stabilization. Her brain tissue is literally overheating, and the enzymes that regulate neurotransmitters are denaturing.
So what's the first nursing action?
The immediate actions indicated are airway, breathing, circulation, and rapid aggressive cooling. The nurse must establish large-bore IV access, initiate massive fluid resuscitation to combat the hypovolemia, and begin mechanical cooling measures.
Like ice packs?
Yes, applying ice packs to the axilla and groin and utilizing cooling blankets.
If the triage nurse had just accepted the neighbor's assumption of dementia, placed her in a quiet room, and waited for a psychiatric evaluation, she would have died.
She would have suffered irreversible brain damage or cardiac arrest within hours. This is why psychiatric nursing is fundamentally medical nursing. You must constantly hunt for the physiological crisis masquerading behind the behavioral symptoms.
And once her core temperature normalizes,
and her intravascular volume is restored, the neurochemical chaos will subside, the delirium will lift, and she will likely be able to tell you exactly who she is and where she lives.
that perfectly illustrates the reversible nature of delirium. So, if delirium demands that we find and fix the underlying medical insult, how does our clinical framework shift when the cognitive decline itself is the primary irreversible disease process?
Well, we shift from managing the acute power surge to managing this slowly degrading hardware. We are entering the pathophysiology of dementia.
The defining characteristic provided by the text is progressive cognitive impairment with no change in level of consciousness.
That is the crucial diagnostic pivot. A patient with advanced dementia may not recognize their own spouse, they may not know what decade it is, but they are awake, they are alert, and their baseline level of consciousness is stable. They do not experience that wild, fluctuating sensorium seen in delirium.
To understand what is actually degrading, the text breaks down cognitive decline into the 4 A's: aphasia, apraxia, agnosia, and disturbance in executive functioning.
Yes, the 4 A's.
I want to isolate these because understanding the literal mechanisms behind these terms changes how a nurse approaches basic patient care. Let's start with aphasia.
Aphasia is the profound deterioration of language function, and it begins very subtly. In the early stages, the patient might just struggle to find the correct noun for a familiar object.
Like calling a pen a writing stick.
Exactly. But as the temporal and frontal lobes atrophy, the linguistic degradation becomes severe. Their speech becomes incredibly vague, relying heavily on pronouns or words like thing.
The text mentions specific vocal tics that develop as well, doesn't it?
Yes, you frequently see echolalia, where the patient uncontrollably echoes the last word spoken to them by the nurse. Or palilalia, which is the continuous repetition of a single word or sound over and over, almost like a vocal tremor.
And it eventually just stops altogether.
Yes, eventually, as the disease ravages the language centers entirely, aphasia culminates in complete mutism.
Wow. Okay, I was reading this section on apraxia, and it struck me as incredibly tragic because their physical muscular strength is completely intact. Am I understanding correctly that a patient might have the grip strength to hold a toothbrush perfectly, but their brain simply drops the how-to file for brushing their teeth?
That is an excellent way to conceptualize it. Apraxia is the impaired ability to execute motor functions despite intact physical ability.
So their muscles work fine.
The motor cortex and the peripheral nerves work flawlessly, but the supplementary motor area, which sequences complex actions, is degraded. You hand them a comb and they possess the strength to hold it, but they might try to eat it. Or they might just stare at it helplessly, completely unable to orchestrate the neurological sequence required to lift their arm and pull the comb through their hair.
Which leads directly into the terror of agnosia. Imagine looking at a dining room table. Your optic nerve is sending perfectly clear, high-definition visual data to your brain, but the visual processing centers refuse to translate those shapes, colors, and textures into the concept of a table. You were just staring at meaningless geometry.
That sensory alienation is agonizing. Agnosia is the inability to recognize or name objects despite completely intact sensory abilities. The eyes work, the ears work, but the brain cannot decode the data.
And this extends to people too, right?
In the later stages of the disease, this extends to facial recognition prosopagnosia. They look into the eyes of the person they have been married to for 50 years and see a complete stranger. They might even look into a mirror and become terrified because they do not recognize their own aging reflection.
The psychological toll of that is unimaginable.
It truly is.
The fourth A is disturbance in executive functioning. Let's talk about that.
This represents the destruction of the frontal lobe's highest capabilities. Executive functioning is our ability to think abstractly, to plan a sequence of events, to initiate an action, to monitor our behavior, and to appraise risk.
So this is where safety really becomes a daily issue.
Absolutely. When this degrades, the patient loses the ability to balance a checkbook, to safely sequence the steps of cooking a meal without causing a fire, or to understand the mortal danger of walking out into a busy intersection.
Those 4As map the general trajectory, but the source text identifies several distinct subtypes of dementia, each with a unique pathophysiological fingerprint. Alzheimer's disease is overwhelmingly the most common, right?
Yes, Alzheimer's accounts for roughly 60% of all dementia diagnoses. It is characterized by a remarkably gradual, insidious onset and a smooth, continuous decline.
And what's actually happening in the brain tissue?
Pathologically, the brain is under attack by two specific proteins. Beta amyloid plaques accumulate in the spaces between nerve cells, essentially suffocating the synapses. Simultaneously, tau proteins inside the neurons collapse into neurofibrillary tangles, destroying the cell's internal transport system.
So the cells are just dying from the inside and outside.
Yes. The neurons die, the brain tissue suffers massive atrophy, and the ventricles, the fluid-filled spaces in the brain, enlarge to fill the void.
How does vascular dementia differ in its progression? Because the mechanism seems entirely vascular rather than protein-based.
Vascular dementia is intimately linked to cardiovascular disease, chronic hypertension, hyperlipidemia, diabetes. The mechanism is a series of microinfarcts, essentially thousands of tiny strokes that choke off the blood supply to distinct geographic sectors of the brain.
So how does that look clinically?
Because the damage is ischemic, the decline is not smooth like Alzheimer's. Vascular dementia is characterized by an abrupt onset followed by a stepwise progression.
Stepwise.
Yes. The patient loses a specific cognitive function, they plateau for a period of time, they suffer another microstroke, they lose more function, and they plateau again.
So the timeline looks like a descending staircase rather than a slope.
Exactly.
What about Lewy body dementia?
Lewy body dementia is driven by abnormal protein deposits called Lewy bodies in the brain cortex. The clinical hallmark that differentiates it is the presence of severe, highly detailed visual hallucinations very early in the disease process, coupled with prominent Parkinsonian motor symptoms.
Like muscle rigidity and tremors.
Yes, tremors and that classic shuffling gait.
Okay, the subtype that seems the most devastating to family dynamics is frontotemporal lobar degeneration, which used to be called Pick's disease.
It is exceptionally difficult for families to process. The frontal lobe acts as our social brake pedal. It regulates our impulses, our empathy, and our assurance to social norms. In frontotemporal dementia, this area atrophies first.
So the earliest signs aren't memory loss.
Right. Consequently, the earliest signs are not necessarily profound memory loss, but rather severe personality changes, emotional blunting, and a complete loss of social inhibitions.
Give me an example of what that looks like.
A previously polite, deeply reserved individual might suddenly begin using aggressive profanity, making wildly inappropriate sexual comments to strangers, or shoplifting without any remorse.
And the family thinks the patient is just choosing to be malicious.
Exactly, when in reality, the neurological hardware for social filtering has simply dissolved.
The text also touches on several other etiologies. Prion diseases like Creutzfeldt-Jakob disease.
Which are caused by infectious, abnormally folded proteins that ravage the brain with terrifying speed, leading to severe dementia and death, often within just a few months.
It also notes chronic traumatic encephalopathy, or CTE, caused by repeated head trauma in athletes.
Yes, that leads to progressive dementia and severe mood instability later in life.
And Korsakoff syndrome, which highlights a very specific behavioral finding.
Korsakoff's is an amnestic disorder induced by chronic, severe alcohol abuse. It causes a profound thiamine deficiency that destroys the brain's ability to consolidate new memories.
And the fascinating finding here is confabulation, right?
Yes. Because the patient cannot remember what happened 5 minutes ago, their brain unconsciously fabricates elaborate, highly detailed stories to fill the gaping holes in their memory. And crucially, they're not lying. They genuinely believe the fabricated reality.
Tracing the progression of all these diseases, the guidelines divide the expected findings into mild, moderate, and severe stages. How does the nursing assessment shift as the patient moves through these phases?
Well, in the mild stage, the hallmark is forgetfulness that noticeably exceeds normal age-related changes. They misplace keys, they struggle to find the right noun during a conversation. But the most significant clinical finding here is the patient's own insight.
Meaning they know it's happening?
They know they're losing their cognitive grip, and this insight generates profound anxiety and secondary depression.
As they transition into the moderate stage, that insight begins to fade. But the physical risks escalate dramatically.
Correct. In the moderate stage, the confusion becomes globally apparent. They lose orientation to time and place. They can no longer manage independent living. They forget to pay bills, or they leave the stove on.
Is this when wandering starts?
This is exactly the stage where wandering becomes a critical, life-threatening safety risk. They leave the house looking for a job they retired from 30 years ago and become hopelessly lost.
And the severe stage is just total systemic failure.
Total dependence. Agnosia is profound. They recognize no one. They lose all ability to perform basic activities of daily living, or ADLs. They require total assistance with bathing, dressing, and toileting. They develop severe gait disturbances, eventually becoming entirely bedbound, and slip into that final state of aphasia or mutism.
This means the priority nursing assessment fundamentally shifts. If you have a patient with Alzheimer's, you aren't assessing them to cure the disease. You are rigorously assessing their ability to navigate their environment safely.
The assessment becomes heavily functional and psychosocial. Can they safely orchestrate the complex sequence of drawing a bath without scalding themselves? Can they manage a weekly pill organizer? Or are they at risk of accidentally overdosing on their antihypertensives?
You also must meticulously assess their nutritional status because of the apraxia we discussed earlier.
Exactly. They don't just forget to eat. They literally forget the mechanical sequence of using utensils. They might stare at a plate of roast beef and mashed potatoes, completely unable to figure out how a knife and fork interact with the food.
Which brings us to the psychosocial nursing interventions. How do we adapt the environment to compensate for that apraxia so they don't starve?
You bypass the need for utensils entirely. You modify their diet to provide high-calorie, nutrient-dense finger foods.
Like what, specifically?
You offer sandwiches, chicken strips, fresh fruit, cheese cubes items they can intuitively pick up and consume without needing to sequence complex motor movements. And if a meal does require cutting, the nurse or caregiver performs that task in the kitchen, completely out of the patient's sight before bringing the plate to the table.
That is such a subtle, profound detail. Why out of sight?
To aggressively preserve their dignity and prevent catastrophic frustration. If you stand over a proud 70-year-old former executive and cut their meat for them like a toddler, you highlight their deficit. If the food arrives pre-cut, it is simply a meal ready to be eaten.
What about managing hygiene and elimination? The text places a massive emphasis on maintaining the patient's lifelong routines.
This is a cornerstone of dementia care. While the hippocampus, which handles recent memories, is destroyed early, the basal ganglia, which stores deeply ingrained procedural memories and habits, remains intact much longer.
So the deep habits survive.
The brain relies desperately on those deep physical grooves. If a patient has taken a warm bath every single evening at 8 p.m. for 60 years, their entire nervous system is calibrated to that routine.
So if an inpatient facility attempts to force them into a 6:00 a.m. shower just because it aligns better with the nursing shift change,
it will result in an explosive, catastrophic emotional reaction. The patient will experience sheer terror, leading to physical aggression, hitting, and biting. You do not disrupt the lifelong routine. You adapt the facility schedule to accommodate the patient's surviving procedural memories.
does that apply to toileting too?
Yes, you establish a strict schedule, taking them to the bathroom every 2 hours, because you cannot rely on them to recognize the internal physiological urge to void, nor can you rely on them to possess the language to ask for help.
Let's transition to the pharmacology of dementia management. If we cannot fix the hard drive, what exactly are these medications doing?
The foundational class of medications are cholinesterase inhibitors, drugs like donepezil, rivastigmine, and galantamine. The mechanism of action is crucial here.
Because in Alzheimer's, the acetylcholine is dropping, right?
Yes, the neurons that produce acetylcholine, which is vital for memory and learning, are actively dying off. These drugs inhibit the enzyme acetylcholinesterase, which normally breaks down acetylcholine in the synaptic cleft.
So by stopping the breakdown, they artificially boost the levels of whatever acetylcholine is still being produced.
Precisely. They do not stop the underlying neuronal death, but they maximize the efficiency of the surviving neurons, temporarily slowing the cognitive decline.
What are the primary nursing considerations when a patient is initiated on donepezil?
The primary adverse effects are gastrointestinal. The nurse must monitor closely for severe nausea, vomiting, and diarrhea, which can lead to rapid dehydration in an older adult.
Are there any more dangerous risks?
Yes, the more dangerous risk to monitor for is gastrointestinal bleeding. The nurse must routinely assess the patient's stool for dark, tarry blood.
The source text briefly mentions an older drug in this class, tacatrine, but notes it is practically obsolete.
Tacatrine was the first cholinesterase inhibitor approved, but it proved to be highly hepatotoxic. It caused severe liver damage in a massive percentage of patients, requiring constant invasive liver enzyme monitoring. It has been almost entirely replaced by donepezil and rivastigmine, which have vastly superior safety profiles.
For the moderate to severe stages, the guidelines introduce a different mechanism of action entirely, NMDA receptor antagonists.
That is memantine. While cholinesterase inhibitors focus on acetylcholine, memantine focuses on glutamate.
What's glutamate doing?
In the later stages of Alzheimer's, damaged cells leak excessive amounts of glutamate into the brain. This excess glutamate persistently activates NMDA receptors, allowing too much calcium to flood into the neurons. And that is highly toxic and accelerates cell death.
So memantine blocks that.
Memantine acts as a shield, blocking the NMDA receptors from this toxic overstimulation. It is frequently prescribed in tandem with donepezil to hit the disease from two neurochemical angles simultaneously.
Now, I want to explore the most cutting-edge pharmacological development in the text, the new monoclonal antibodies. Medications like lecanemab, marketed as Leqembi and donanemab, these seem to represent a paradigm shift.
They absolutely are. Everything we just discussed at donepezil memantine is purely symptom management. They do not alter the underlying pathology. Lecanemab and donanemab are amyloid beta-directed antibodies.
How do they work?
They are engineered to explicitly target the toxic beta-amyloid plaques accumulating in the brain tissue, bind to them, and flag them so the patient's own immune system can attack and clear the plaques.
That sounds remarkably close to a cure.
It is the first disease-modifying therapy we have, but we must manage expectations. It is not a cure. It has been shown to modestly slow the rate of clinical decline in patients who are in the very early, mild stages of the disease. Furthermore, the logistics and risks are massive.
Right, because these aren't just pills you take at home.
No, They require regular, supervised intravenous infusions.
And the nursing considerations for these infusions include a very specific severe adverse effect.
Yes, the nurse must monitor for immediate infusion reactions, chills, flushing, sudden fever. But the critical, life-threatening risk that requires intense monitoring is ARIA, amyloid-related imaging abnormalities.
What is that?
As the immune system aggressively clears the plaques from the brain's blood vessels, it can cause severe, temporary swelling of the brain tissue or actual microhemorrhages and bleeding in the brain.
Oh, wow. So what is the nurse looking for?
The nurse must be hypervigilant for any sudden onset of severe headache, visual changes, acute dizziness, or a sudden dramatic worsening of confusion that signals rising intracranial pressure.
The text also covers symptom management for the secondary psychiatric issues that accompany dementia. Depression is incredibly common in the early stages when insight is intact, right?
Yes, and selective serotonin reuptake inhibitors, or SSRIs, are the first-line treatment for that depression because they lack the severe anticholinergic side effects of older antidepressants, making them much safer for an already compromised brain.
And for hallucinations.
For the terrifying visual hallucinations associated with Parkinson's disease dementia, a specialized medication called pimavanserin is utilized.
Which brings us back to that monumental black box warning we touched on in the 80-20 section.
The antipsychotics.
Right. If a patient with severe Alzheimer's is exhibiting violent paranoia, perhaps they believe the nursing staff is trying to murder them, and they are physically attacking anyone who approaches, the instinct is to use a heavy tranquilizer.
The instinct is to reach for haloperidol or risperidone to chemically subdue the patient. But the FDA black box warning explicitly states that using conventional or atypical antipsychotics to treat dementia-related psychosis significantly increases the mortality rate.
Their bodies just can't handle it.
The cardiovascular system simply cannot handle the pharmacological load. It is a grueling risk-benefit analysis for the provider. Antipsychotics are only used off-label when the patient's aggression presents an imminent, unavoidable danger to themselves or others, and only after every possible non-pharmacological behavioral intervention has completely failed.
So let's dive deep into those behavioral interventions, specifically the therapeutic communication strategies. This is where we need to unpack the difference between orienting someone and validating them.
A vital distinction.
If a female patient with advanced dementia is frantically pacing the hallway crying and stating she needs to go to the elementary school right now because she forgot to pick up her children in 1984, why is it clinical malpractice to gently remind her that it is 2026 and her children are in their 50s?
Because of the neurobiology of grief and memory consolidation. To understand why reality orientation is cruelty here, you have to look at the hippocampus. Her brain has physically lost the capacity to retain new information.
So she won't even remember your correction.
Exactly. If you tell her the truth that her children are grown and her husband has passed away, you are not orienting her to the present. You are forcing her to experience the raw, agonizing shock of her husband's death for the very first time. She will experience all the autonomic panic and despair of acute grief.
And because her short-term memory is destroyed, she won't retain the logical explanation you just gave her.
Right. 5 minutes later, the explanation vanishes, but the devastating emotional trauma remains circulating in her nervous system. She is left feeling terrified and heartbroken without knowing why. You cannot force a broken brain to learn a new reality. You are just traumatizing them on a continuous loop.
So the nursing intervention must completely bypass objective reality and target the emotional reality. The text lists specific, highly effective strategies. Let's start with distraction.
Distraction is the art of shifting their limited cognitive focus to a neutral or pleasant stimulus. If a patient is agitated, yelling that the food on their plate is poisoned, you do not waste time arguing the chemical safety of the mashed potatoes.
They don't try to prove it safe.
No, you simply say, you can leave that food right there, come walk with me, let's go look at the garden outside.
Here.
You smoothly redirect their kinetic energy away from the trigger.
What if distraction fails and the patient's agitation escalates into verbal hostility toward the nurse? The strategy listed is time away.
Time away capitalizes on the patient's profound short-term memory deficit. If you are attempting to help a patient bathe and they become intensely angry, yelling and raising their hands to strike you, you must ensure they are physically safe in the room, and then you step out.
Just leave.
You leave the environment for 5 to 10 minutes. When you return, you re-enter with a completely neutral, warm demeanor. Because their working memory is destroyed, they likely will have absolutely no recollection that they were just furious with you, and the baiting process can be restarted smoothly.
The strategy of going along feels the most counterintuitive to me because it essentially requires the nurse to participate in the delusion.
It requires the nurse to prioritize emotional safety over factual accuracy. If that patient is pacing, wringing her hands, terrified about her small children, going along means you provide the exact emotional reassurance her brain is desperately seeking.
What do you say?
You say, there is no need to worry, the children are perfectly safe, they are well cared for, and everything is fine. You meet her in her reality, provide the emotional antidote to her panic, and allow her nervous system to de-escalate.
That is profound empathy. The next strategy is reframing.
Reframing is utilized when a real external stimulus is causing the patient terror. If another patient down the hall is screaming loudly, and your patient cowers, believing the facility is under attack by armed intruders, you reframe the auditory data.
So you change the context.
You say, that lady down the hall is having a very frustrating day, and she yells when she is upset. You take the terrifying stimulus and construct a safe, logical, non-threatening frame around it.
The final strategy listed is reminiscence therapy, which seems to beautifully leverage the specific way memory degrades in dementia.
It is a phenomenal therapeutic tool. While the disease rapidly obliterates recent short-term memory, the deep, remote, long-term memories remain crystallized and intact for years. Reminiscence therapy actively utilizes those intact neural pathways.
Like looking at old photos.
Exactly. You sit with the patient and look through old photo albums. You ask them to recount stories from their career or their military service or their wedding day. Because they can access these memories flawlessly, it drastically reduces their anxiety, combats their profound isolation, and allows them to reconnect with their identity as a competent, accomplished human being rather than a confused patient.
That perfectly highlights the humanity at the core of this care. And it leads us directly into our final major area of discussion. When treating a patient with progressive dementia, the medical team is never just treating an isolated individual.
Never. The patient is only half the clinical picture.
You are always treating the family unit. The hidden patient in every dementia case is the primary caregiver.
The hidden patient. It's so true.
The text places massive emphasis on caregiver role strain as a high-yield clinical concept. Let's define the demographics of this hidden patient. Who is actually shouldering this burden?
Statistically, 2/3 of all dementia caregivers are women. Very frequently, the primary caregiver is an adult daughter. And the psychological burden they carry is staggering because they are experiencing a profound, grueling role reversal.
They are forced to parent their own parents.
Yes. They are navigating the emotional devastation of watching their mother's mind dissolve, while simultaneously managing the physical exhaustion of feeding her, managing her incontinence, and staying awake all night to ensure she doesn't wander out the front door.
So when a home health nurse or a clinic nurse encounters this family unit, what are the specific assessment findings that indicate the caregiver is reaching a dangerous breaking point?
The nurse must rigorously assess the caregiver for signs of unrelieved chronic fatigue. You look for severe social isolation. Have they completely abandoned their own friends and hobbies because the patient cannot be left alone for 5 minutes?
As substance use, right?
Yes. You assess for increased maladaptive substance use, such as drinking heavily every night just to cope with the stress, and you listen for overwhelming, toxic expressions of guilt, the caregiver feeling that they are constantly failing no matter how hard they work.
And the clinical red flag tied to severe caregiver role strain is terrifying.
It is the primary risk factor for elder abuse and neglect. If a caregiver is pushed entirely beyond their physical and psychological breaking point, the patient is in imminent danger of being harmed, intentionally or unintentionally.
Therefore, nursing interventions for the caregiver are quite literally safety interventions for the patient. What tools do we provide them?
The absolute first intervention is comprehensive, mandatory education regarding the disease's pathophysiology.
Because they need to know it's the disease, not the person.
Exactly. Caregivers must be taught that the catastrophic emotional reactions, the paranoia, the cruel accusations, it is the neurobiology of the disease speaking, not the person they love. They have to understand that when their father accuses them of stealing his money, it is a symptom of temporal lobe atrophy, not a genuine judgment of their character.
That prevents them from taking the behavioral outbursts personally.
Which is the fastest route to resentment.
And practically, we have to provide them with physical relief.
The nurse must actively orchestrate referrals to adult daycare centers, where the patient can be safely managed in a therapeutic environment during the day, allowing the caregiver to maintain their own employment or simply sleep.
And respite care.
And respite care services, which provide temporary, short-term inpatient or in-home care to give the family a vital physical and psychological vacation from the relentless demands of the disease.
We must fundamentally reframe how caregivers view their own needs. We have to make it clear that self-care is not a selfish luxury. It is a strict clinical requirement for safe patient care.
If the caregiver collapses from a heart attack due to chronic stress, the patient is left entirely defenseless.
Precisely. You cannot pour from an empty cup. Let's touch on the cultural considerations in assessment. The source material highlights that diagnosing cognitive decline is fraught with cultural landmines.
It really is.
It strikes me that a standard mini-mental state exam where you ask a patient to name the current U.S. president or state the exact date might be entirely invalid depending on the patient's background.
It is an incredibly vital point of clinical equity. Cognitive assessments must be rigorously tailored to be culturally appropriate. If you are assessing an immigrant elder who does not consume Western political media, their inability to name the president is not an indicator of aphasia or memory loss. It is merely a reflection of their cultural focus.
That makes so much sense.
Furthermore, if a patient comes from a culture or religion that strictly does not observe or celebrate birthdays, they may hesitate or stumble when asked for their exact date of birth. A culturally incompetent nurse might document that as disorientation to self, which is a catastrophic misdiagnosis. You must establish the patient's baseline knowledge within the context of their own lived experience.
The text also emphasizes that cultural values dictate how the family navigates the diagnosis itself. In many cultures, elders retain ultimate, unquestioned authority and deep reverence, regardless of their cognitive degradation.
Yes. In many communities, stripping an elder of their autonomy, taking away their car keys, or making medical decisions on their behalf is viewed as a profound, unforgivable disrespect. The family may actively refuse to intervene out of deference to the elder's traditional authority.
How does a nurse handle that?
The nurse must navigate this dynamic with immense tact. You cannot just bulldoze the family with medical mandates. You must collaboratively design a care plan that ensures the patient's physical safety while meticulously preserving the family's need to honor and respect their revered elder.
We have covered a massive expanse of clinical ground today, moving from the acute chaos of the emergency department to the slow, agonizing decline managed in the home. Let's synthesize this journey.
Let's recap. We established the critical baseline. Delirium is an acute, fluctuating, reversible medical crisis. It is a power surge crashing the system. It demands that the nurse play detective, locate the physiological insult, the UTI, the hypoxia, the polypharmacy, and correct it, while utilizing strict reality orientation to ground the patient.
And dementia, conversely, is a chronic, insidious, irreversible degradation of the brain's physical hardware. The level of consciousness remains stable while the cognitive capacity dissolves. It demands that the nurse utilize validation therapy, adapt the physical environment to accommodate apraxia and agnosia, and aggressively support the hidden patient, the exhausted caregiver.
Understanding those opposing mechanisms is what separates a technician from an elite clinician.
I want to leave you, the listener, with a final provocative thought to mull over. We pulled this from the mental health promotion section of the text. We have spent this entire deep dive discussing how to manage the devastation of cognitive decline, fixing the power surges, and adapting to the failing hard drives. But the text hints at the frontier of prevention.
The research is absolutely fascinating. Studies have identified that elevated plasma homocysteine levels are a massive independent risk factor for the development of dementia.
Wait, really?
Yes, and clinical trials are actively investigating whether simple targeted supplementation with B vitamins and folate to lower those homocysteine levels can fundamentally alter the trajectory and prevent the onset of Alzheimer's pathology.
It also explores the concept of actively building cognitive reserve.
This is the neurobiological equivalent of building a savings account for your brain. The research suggests that engaging in complex, novel tasks throughout midlife, learning a new language, reading dense literature, navigating a vibrant social network, and maintaining rigorous cardiovascular fitness literally forces the brain to build millions of extrasynaptic pathways.
So it's like a buffer.
It creates a dense, redundant reserve of cognition that can physically withstand the encroaching pathology of dementia for years or even decades, longer than a brain without that reserve.
Which begs a very personal, challenging question for you. As a dedicated clinician, a nursing student, a healthcare provider who spends long, grueling shifts caring for failing brains and managing the cognitive decline of others, what are you actively doing today to build the dense, protective, cognitive reserve of your own brain?
It is a question that requires immediate daily action.
We encourage you to take this high-yield knowledge, the pathophysiology, the pharmacological red flags, the nuanced communication strategies, into your exams and directly to the bedside. You possess the theoretical framework now to ensure safer, more compassionate, and highly precise patient care. Remember, the diagnostic picture will frequently be murky and the X-ray machine will be broken. But with a rigorous understanding of the underlying neurobiology, you can always clear the muddy waters. Thank you for taking this deep dive with us.